Thank you, Alberto. So that's your time. Yeah. We're waiting for his invoice, at the end of the program.
Thank you, François, and thank you to Allergan MV Laboratory for giving me the opportunity to speak today about intramuscular block. This is my links of interest with the three botulinum toxin laboratories. Anatomy is essential to understand the different type of anesthetic block. As you can see, we have an extramuscular portions for the perineural blocks at this part, okay, and an intramuscular portion nerve that can be reached with an intramuscular block. With the Sealer method, this is the Sealer method, okay, it is possible to visualize the nerve branches and the position of the neuromuscular junctions that can be targeted by an intramuscular anesthetic block. Recent French recommendation from the Society of Anesthesia and PRM recommends that blocks be performed as selectively as possible, allowing a finer clinical assessment, a lower dose of local anesthetic agent, and an outcome closer to that obtained with the durable therapy. In the same way, always with the Sealer method, it is possible to observe the intramuscular nervous pathway, and these pathways are more and more visible in the ultrasound technique, as you can see here, the intramuscular branches. So, why performing an intramuscular anesthetic block? Setting up perineural blocks everywhere in France remaining challenging because of technically demanding. Any botulinum toxin injector is able to perform an intramuscular block because it's the same technique, predictive of botulinum toxin injection efficacy. And this technique is highly selective and perhaps have a place to take in the evaluation strategy, but needs to be better defined. The primary requirement is a good knowledge of anatomy. For example, in this muscle, the semitendinosus has two different compartments with two distinct motor points, here and here. If you do not perform two selective injection points for this muscle, for toxin or for anesthesia block, the intramuscular block may not work. This is an example of a dystonia associated with the claw of the toes of the left foot, as you can see. And I made an injection of 1 mile of 1% lidocaine in the abductor hallucis muscles. And we obtained a complete involution of the claw after only 2 minutes. And the response duration is during 20 minutes. A second example is a problem of knee flexum. A clinical examination is in favor of spasticity of the semimembranosus and semitendinosus muscles. And I made an injection of 5 miles of lidocaine 1% in each muscle in 2 injection points because of the 2 compartments. And as you can see, we have a gain of 50% of range of motion. So it has been proposed the constitution of a French national expert group under Philippe de Normandie leadership. It has been sent a survey comprising 17 questions. The first board meeting held on January 21, and the first draft of consensus summarizing key points in March of this year. And we have a publication plan of the expert panel consensus in progress, upcoming project of a national multi-center register. So the first question is which patients? This is the panel response are any patients you need to suppress the action of a muscles with troublesome muscles hyperactivity. If you have a doubt of the site to be injecting with botulinum toxin, you can make an intramuscular block. And if you need to predict the effectiveness of botulinum toxin or to document a decrease in functional motor ability. In summary, all patients with a neurological impairment with spasticity or involuntary muscles hyperactivity to delineate the therapeutical strategy. The second question is objective and contracts. The panel response are to distinguish muscles hypertonia from retraction. Impact of a potential treatment of hyperactivity, according to the pattern of the muscles responsible, on the functional capacity of the patients. And to help defining the objectives of treatment by toxin, neurotomy, phenol injection versus surgery. And this technique to facilitate the contract with the patients about goals using a reversible functional evaluations at the short time. Which muscles? It is the same at the botulinum toxin injection for most cases. Muscles for which there is no possibility to perform a perineural truncular blocks, discrimination of another muscles innervated by the same nerve trunks. This is a selective block. And of course, it's necessary to know the anatomy and the muscles volume, the neuromuscular junction, positions, and the type of muscles. According to the bibliography, there is no exhaustive list of potential targets described and no arguments in the literature against the use of one specific motor block versus another one. This is a selective block, should be prioritized. Which anesthetic agent? There is a consensus. It's a lidocaine 1% and ropivacaine. According to the French recommendation, lidocaine non-adrenalized and ropivacaine if you use a more longer effect. There is no indication of adrenalized. The action of lidocaine is in 5 or 10 minutes, depending on the injection. The duration of action from 1 hour and a half and 2 hours. Ropivacaine, action in 15 minutes, depending on the injection site, and the duration of action is about 6 or maybe 10 hours. It's important to know the lidocaine side effect, as you can see, and the occurrence of an adverse reaction should raise the suspicion of an overdose. We have a question. Because of the perineural blocks, injection of anesthetic agents diffuse to neighboring anatomical structure, and it's possible to have a neurotoxicity and a myotoxicity. About neurotoxicity is mostly described with lidocaine, but for spinal anesthesia. For myotoxicity, we have a recent review on epidural analysis, and this is important for high concentration of long exposure. But lidocaine is the least toxic anesthetic agent. This is an important fact. In this literature review on epidural analysis, there is no indication of a minimum toxic dose. In summary, there is a dose-dependent toxicity, a place and speed of injection to consider, and it's indicates to limit the use of lidocaine and ropivacaine dose. Which recommended doses per muscles? Unfortunately, there is no consensus, and bibliography does not permit to make recommendation. This is the answer of all the panel. Bibliography in perineural blocks for lidocaine, the effective dosage is about 50 milligrams with a maximum dosage of 300 milligrams. And for ropivacaine, they have an effective dosage again in 50 milligrams and a maximum dosage of 150 milligrams. In PMR practice, we are exclusively in level 1 of use of lidocaine, up to 2 milligrams per kilograms. It's necessary to check up the contraindication, no pre-anesthetic consultation, no anesthesiology present required, no approach, no monitoring, and we have intralipid 20% available nearby. There is no consensus, and it's a very difficult part, and the doses depend probably of the size, the volume, the number of interventions of the muscles. effective doses is probably in 50 milligrams, so 5 mils of lidocaine 1%. But we have a remaining question. Dose indicate for perineural blocks, but which dose was been to use per muscles? Recommended time between two injections. There is no consensus again. In bibliography, only for perineural blocks, time to be respected between two perineural blocks, for lidocaine, for example, is 60 minutes. A remaining question is the data between two infiltrations are known for the perineal nerve, but what would be the optimal interval between two intramuscular injections? What about anticoagulant and antiaggregant management? There is no consensus. The bibliography can make an answer. For anticoagulant treatment, the major message is do not take the risk of stopping an effective anticoagulant treatment for a procedure that is not vital. It's necessary to distinguish between low-risk block and high-risk blocks in case of effective anticoagulation. For antivitamin K, a recommendation of an ENR between 2 and 3 in the day preceding the procedure, and low prevalence of bleeding, muscle hematoma, and compartment syndrome if therapeutic procedure performed with an ENR within recommending therapeutic doses, even when deep muscles are targeted. For direct oral anticoagulants, the French Society recommend with a minor bleeding risk and to stop 24 hours before an intervention. And for moderate and major bleeding risk, an interruption of treatment of 28 before the operations. In North America, low-risk procedure for block on intramuscular injection, no stop is required. It's easy for antiplatelet agent because no need to stop taking aspirin and no need to stop about clopidogrel and ticagrelor. Contraindication. The contraindication is well known, is well documented in hypersensitivity to lidocaine, hydrochloroquine, the Brugada syndrome, patient with porphyria, and is well known. The procedure. This is the procedure of the panel in a one-day hospital after a medical clinical assessment. Necessity to perform an EKG or insert a peripheral venous catheter with the precaution, and in level 1 this is not necessary, but maybe it's a good idea. Oral information with explanation of the indication of the proposed procedure. A possibility written information given to the patient with a signature of consent. And this is a clean gesture with non-sterile gloves. The precaution is the level 1, I remember. About the injection material, this is the needle usually used for toxin injection, and the size depends on the muscles to be injected, its depth and its patient build. For the tracking technique, electrostimulation and or ultrasound technique can use, and there is no proven superiority of one over the others. About the patient preparation, no preparation is required, but a pre-medication can propose, if it's necessary, a non-pharmacological technique like hypnosis or virtual reality can be used. In the bibliography, all non-medical techniques can be useful in additions, and particularly on the pedagogic gesture, as you can see in Poitiers when I use the virtual reality for injection. About efficacy assessment, there is no consensus. Question raised by the panel to control the effectiveness is maybe one of the weak points of intramuscular block. When the procedure is performed under ultrasound, we are sure that it is injected in the right place, but when the ultrasound location is not obvious, being sure of the effectiveness is questionable. In bibliography, an analytic evaluation it's necessary, and the evaluation of the subjective feeling of the patient, particularly when he's working, or the caregivers, it's primordial. How long shall we wait before injecting botulinum toxin after intramuscular blocks? This is a major question. There is no consensus, and the literature have an interesting data. There is one serious effect, an anaphylaxis, and one case of patient deceased after receiving an injection of Botox inappropriately diluted with 5 millimeters of 1 lidocaine. This is a little bit surprise, because in several studies, lidocaine is used with the botulinum toxin, like in this study, evaluation of the safety of intra-articular injection in arthritic shoulder pain, and the group 1 have an injection of lidocaine 1%, then 100 units of Botox, and we have only one common adverse event, a chest pain, like the placebo. In other studies, we have an evaluation of efficacy of Botox in axillary hyperhidrosis, and no adverse effects other than pain at the time of the injection were noted. And other studies, an evaluation of efficacy on pain and axillary hydrosis, we have only a minor adverse effects, hematoma and fatigue after injection. For Xeomin, no clinically significant interaction have been reported between botulinum toxin and other products. There is an open question. Would the possibility of concomitant injection of botulinum toxin and lidocaine reduce the delay between two injections or allow them to be done almost consecutively? For the patient information, is a priority. All the panel said that. Oral and written information collection of written consent regarding the procedure, regarding the injecting agent, of the evaluation supporting, if possible, by a brochure. In the bibliography, documentation of the delivery of information and collection of consent must be inserted in the medical records and is recommended not to perform the procedure at the same day of the first consultation with the patient. About the training of the PN physician, this is a training identical to botulinum toxin injection or perineural motor blocks, and the practice of motor blocks record training in their indication and must be provided by initial and continuing PRM training. Which place for intramuscular blocks in the armamentarium for patients with motor disability? The panel says the motor branch difficult to access or inaccessible to relays on the perineural motor blocks. When we have difficulties to accessibility due to the depth or size of the muscles, small muscles for example, or when we are necessity to block several muscles, but of a varied truncal innervation. You can precise evaluation of muscles whose nerve branch are difficult to individuals, and for the example of dystonia, for the trigger muscles, in case of failure of previous treatment in preoperative or as a complement of the perineural blocks in focal spasticity and dystonia. And finally, the prediction of the effectiveness of botulinum toxin. So this is the take-home message. The intramuscular block have a real place in the strategy and diagnostic and pre-therapeutic strategy, but to be well defined, a predictive value of botulinum toxin injection, and a new tool in a clinician toolbox, and this is a robust knowledge of neuroanatomy key. Thank you for your attention.
Okay, thank you so much, Romain. There is obviously some question. I saw that maybe Paul just behind you, and after.
So there's many companies coming out with long-lasting bupivacaine and experimental lidocaine that have duration of access of 4 days or even 1 month because of the liposomal storage. Have you seen or tried to use any long-acting agents for nerve blocks?
We practiced anesthesia blocks during 2 years ago with Philippe de Normandie, and we make the injection of botulinum toxin directly after the intramuscular block anesthetic.
Je veux dire qu'il y a les lidocaine qui durent pour 4 jours ou un mois. Il y a, aux États-Unis, vous avez un bupivacaine liposomal, alors il dure beaucoup de temps. Est-ce que vous avez essayé avec ces anesthésiques qui a une duration d'une semaine, un mois?
We use only lidocaine 1% during with the duration of 30 minutes, and ropivacaine during in your experience 4 hours. Only that.
In the past, we had etidocaine, which is not on the market anymore. It was really interesting because it was a selective motor agent. But for anesthesiologists, it was a bad agent because patient feel everything, but he was paralyzed, but feel. But you point out the relation between toxin and lidocaine, and for a long time, I had the dream to mix both and to do it systematically, because when you inject your toxin, you have the question, what will be the result in 1 month? And so you may maybe predict what the toxin will be the result. And each time I ask clever guys, more than myself, like Alberto and so on, the answer was you have a risk of diffusion due to the vasodilatation effect of the anesthetics. So you cite two paper, intra-articular hyperhidrosis, and what is your opinion about the fact that to routinely mix lidocaine and toxin in our daily practice? And do you have any data in the literature on animals and with regard to safety?
There is no argument about safety with the intramuscular blocks. For me, this is not a routine. This is a routine technique, but just for the diagnostic, in order to show for the patients for one.
So if I understand correctly here, their intent was not as a treatment, but really as a selection. That's what your objective is.
Exactly.
And so making it last longer doesn't switch what you're trying to do. You're trying to define, is this the right muscle to inject? That's what they're doing.
Yes, but Alberto, we have the experience that when we mix, we prepare the botulinum toxin with NaCl, and after we had some anesthetics such as ropivacaine, but even the other, lidocaine, we have sometimes a very long effect of the, you inject into the muscle, about 10-15 minutes, the patient resent, a decrease in the pain and increase in the muscle and that stuff, and sometimes it lasts for several days, even several weeks, and after the botulinum toxin is going, increasing, and so I am totally very, very surprised with this, long-acting action. Yes, I think with dystonia, and yes, maybe that's it. Maybe that's it.
Sorry, I think I don't know, François. What do you think about this topic? But I have seen this effect in dystonia, and probably the duration of the anesthetic effect it depends of the kind of hypertonia, because we talk about spasticity, but it's not all. Yes.
You're going to have to wait now.
Yes, thank you. Do we have an experience of that kind of test on our sometime hard dystonia about cerebral palsy and young people with great torticollis, spastic dystonia, and do we have some experience about that? Could it be efficient? Because with toxina we have some small effect, and
I never try. Only in the upper of lower limbs. I'm sorry.
Now you can go back. I'll come back to you.
I'm sorry to insist, but Alberto, I would like to know, what do you think to routinely mixed lidocaine and toxin when you routinely treat your patients? For instance, where I inject finger flexors, I suspect it's more FDS or FDP, so I will inject 50-50, for instance, but I'm not sure about the result. I will know it 1 month later. Maybe I will have the answer immediately and put it in my file, and then the next time I have to change. What do you think about this proposition?
Yeah, it's a good idea. The problem is that if you ask any of the companies, can I mix it, they'll tell you no, because there is no proof. So if something happens to the patient, the one who's in deep water is you, nobody else. So just keep that in mind. In the US, I pay nearly $20,000 a year for malpractice. So I don't want to test that in a public forum. There was one question here.
It's the same answer for 20 years.
Oh, here, sorry.
Thank you. Is it any paper with association with adrenaline?
No.
Because of duration, because of diffusion of the product? No, you
No
never
paper.
try and you never learn about it? No.
So the one point that I will make, someone was talking about motor-specific local anesthetics or short-acting anesthetics. There are some very interesting old papers. These are very old papers that look at lidocaine at 1%, lidocaine at 1.5%, lidocaine at 2%, and its effect on motor fibers. 1.5 is the most motor specific. So you could take a mixture of 1% and 2%, make 1.5%, and use that as your injection substrate. So just...
Thank you for this information.
There was one more question.
Merci beaucoup Romain. Finalement, je trouve quand même il y a une question qu'il faut qu'on règle également, c'est pourquoi pas pousser plus la lidocaïne avec de l'adrénaline quand on est en intramusculaire. Parce que ça réglerait de façon beaucoup plus simple nos problèmes d'anticoagulants, puisqu'on a quand même un phénomène de vasoconstriction. Donc est-ce qu'on n'a pas un intérêt, en tout cas ça ne mérite pas qu'on se pose des questions, y a-t-il un risque de faire de la lidocaïne avec une lidocaïne adrénalinée quand on fait dans des injections intramusculaires. En chirurgie, quand on fait des chirurgies avec des anesthésies locales, souvent, on met directement sous-cutané dans le muscle de la lidocaïne adrénalinée pour que ça saigne moins. Donc je pense que là, il faut qu'on creuse également ce sujet. Parce qu'on n'est pas en périneural, donc ça change tout.
The question is the use of adrenaline adrenalized because of the in lidocaine, because we have a vascularization intramuscles, and I think it's a good idea. But in the recommendation for the perineural nerve, there is no recommendation for non-adrenalizant. So if you have a problem about safety.
Yes, but I think, as it was said by Philippe, if it creates some vasoconstriction, it's a really good idea just to think about it and maybe to try. I think it's a really good point. Yeah. But we have to create a study, so maybe an international study, no? Okay. Is there any other question? Yes, Olaf. Sorry, Jamel Ben Smail, Yari Thibault Noré, over there.
You mentioned several times the predictive value of the effect of motor block in intramuscular block. I totally agree with you for spastic patients, but for dystonic patients, it's totally different problem. And I think we have to keep attention about in dystonic patients, dystonic movement disorder, the predictive value is not so good. And we have hundreds of cases of patients without a good outcome of botulinum toxin, whereas with the motor block and the intramuscular block, it was very good outcome. So for the young people, we have to.
I totally agree. The difficulty is the treatment of dystonia, because the intramuscular block is spectacular, but the treatment doesn't work sometimes.
For the rectus femoris, have you, for example, compared the intramuscular block and the perineural block? Which one is more efficient?
Yes, for me, intramuscular block is not the same of perineural blocks. We have two different type of blocks. If you make a good intramuscular with a good compartment, with 3 points minimum, is the same effect as usual.
Okay.
Hold on, because they need to translate it, and they can't hear you back there.
C'est le problème des vieux, tu sais. Non, mais je réagis sur ce que disait Jamel, parce qu'on n'en a pas parlé du tout, mais on sait faire ces anesthésies intramusculaires. Chez nos patients dystoniques, est-ce qu'il faut, là encore, qu'on ne travaille pas plus sur le phénol intramusculaire? La toxine ne marche pas, à ce moment-là, rentrons dans le phénol. Qu'est-ce que tu en penses?
I think it makes sense to use phenol there, but you know, it's. I think dystonia continues to be a problem understanding exactly how it reacts. So.
Okay, so thank you so much. Sorry, but it's time to have lunch. Keep your headphone or put it on your chair because it's not possible to clean them for this afternoon. So we are going to have lunch and we're going to be back at 2 o'clock. Okay? And sorry, yes, thank you, Romain. And we have to get, because he's opening, a new door in our, therapeutic strategy.